Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Sami, 35 years old, presented with complaint of inability to walk. Please take history and examine the patient, address his concern.
Hello.
Ready? Yes, here you go.
Yes,
Hello.
hello, doctor. Yes, hello,
I'm
doctor.
Dr. Auda. I'm Dr. Auda Karim. I'm one of the doctor covering the service today. May I confirm that you are Mr. Sami, 35 years old?
Yes, doctor, I'm saying.
Mr. Sami, we are here to talk regarding your health condition. After that, I want to examine you and we can address your concern. Is that okay with you?
Thanks, doctor. Yes.
Okay. So could you tell me what brought you here today?
Yes, doctor, I have difficulty of walking. I can't walk. That's why I came to the hospital.
I'm sorry for that. What do you mean exactly by difficulty in walking?
Yes, doctor, I think there is some pain. I can't walk.
You have a pain, you mean?
Yes, doctor.
Okay. So when it started for you exactly?
Started since 2 days.
Is it first time or you have
No,
previous episode before?
no, doctor, I have many previous episodes,
Okay.
but
Okay,
this is,
so
it is now increasing.
now increasing.
Yes,
Not
doctor.
okay. Is it similar like previous
Yes,
episode?
doctor. Yes, doctor, I think it is the same, but the last time it is more severe.
When's the last one?
Since 2 days.
Yeah, before this, I mean.
Comes many times, doctor. Many times.
Okay.
The
Okay.
first time, yes, the first time was 1 year back.
Years back. Okay.
Mhm.
Okay. So do you have any trauma to your leg?
No.
Any weakness in your leg?
Weakness, no.
Okay. Regarding this pain, okay, this where is the site of your pain exactly?
I think it is in my in whole my leg.
In the back of your leg or just in all of your
In
leg?
the, I can't know, doctor, but it is in the whole leg.
Okay. So this pain, is it worsening when you are moving?
No, doctor.
Okay. Is it anything to improve it, like when you are at rest?
When I what? I'm sorry.
At rest, at rest.
It is no, doctor. It is worsening with rest.
Worsening with rest. Okay.
Yes.
Okay. So do you have yeah. Okay. Did you injure yourself or any falling down before?
No, doctor, never.
Okay. So do you have any change in sensation, numbness, or tingling sensation in your leg?
Tingling, no, doctor.
Okay. Okay. So you are told me the no weakness. Am I right?
No weakness, doctor.
Okay. Do you have any back pain?
Yes, doctor.
Okay. Where is the site of your back pain exactly?
Yes, doctor. In the lower back.
Okay. So when it started for you?
Started since 1 year, doctor. Yeah, also.
Okay. So this back pain, is it worsening with at rest or with movement?
I think, doctor, when I move it helps me. It helped me a lot. Yes.
Okay. Okay. So is there any stiffness?
Yes, doctor. There is stiffness. There is morning stiffness.
For how long continue for you?
Stiffness, I think, for 20 minutes in the morning. When I move or I go anywhere, it is improved.
Okay. Okay. The nature of this back pain?
It is dull aching, doctor.
Okay. Do you have any trauma to your back?
No.
Okay. Is it going anywhere else?
No, doctor. I don't think so.
Okay. Okay. So if I give you score 1 for me and 10 for Max, how can you score your back pain? No.
Yes, doctor. I think it is between 3 and 4.
Okay. I'm sorry for that. I'm trying to give you a painkiller.
Thank you,
Okay.
sir.
Okay.
Thanks.
So do you have any pain another part in your body?
Like what?
Yeah, like in your neck.
No, doctor.
Okay. Any restriction of movement in your neck or in your back?
I don't know, doctor.
Okay. So do you have any skin rash now or before?
No, doctor. No,
Any skin rash behind your ears, at the hairline?
I don't think so, doctor. I can't see behind my ear.
Okay. Do you have any pain when you are touch your muscle?
No, I don't think so.
Any difficulty in combing your hair?
No,
Any soreness in your mouth?
no.
Okay. Do you have any redness in your eyes now or
Yes,
before?
yes, doctor. I think my eyes sometimes it become red.
Mm-hmm. Okay. Any grittiness or dryness in your eyes?
No, but there is some discharge from my eye in the morning.
Mm-hmm. Mm-hmm. Okay. Okay. So apart from that, do you have any high body temperature?
No, doctor.
Do you have any weight change?
With a change, no,
Mm-hmm. Any lump or bump in your body?
never, doctor.
Okay. Any night sweat?
No,
Anyone commit for you or become better than usual?
no, no.
Okay. Can I see my patient?
Okay.
Okay. So do you have any medical background I should be aware of?
No, doctor.
Okay. Any surgical procedure before?
No,
Okay. So do you have any headache?
headache, no.
Okay. Any okay. Yeah. Any vision problem apart from this pain in your eyes?
Yes, some bleeding of vision, doctor.
Mm-hmm. Mm-hmm.
Yes,
Okay. Okay. Do you have any weakness anywhere in your body?
no.
Mm-hmm. Okay. Do you have any cough?
Cough, no.
Any shortness of breath?
No,
Any swelling in your leg?
no,
Any chest pain?
no,
Awareness of your heartbeat?
no,
Any change in the bowel habit?
no, doctor.
Any tummy pain?
No.
Okay. Do you have any change in the water work regarding the amount, color?
Amount to color, no.
Okay. I'm sorry for asking these questions. Yeah. Any discharge from your private area?
No, doctor.
Any pain while you are bathing your water work?
No, doctor.
Okay. Okay. So,
Mm.
okay. Okay. So, yeah. Could you show me your medication list, please?
Apart from painkiller, no medication, this doctor.
Okay. So, how frequent you are take the painkiller?
Yes,
And what
doctor.
medication exactly?
I take only paracetamol as painkiller for my back pain and also my leg pain.
Mm-hmm.
So
Mm-hmm.
I think I take one tablet or two tablet per day, or yes,
Mm-hmm.
per day.
Mm-hmm. Mm-hmm. Okay. So do you have any heart pain, acid brush,
No, doctor.
any black color change of your motion?
No, doctor.
I'm sorry for asking this question. Any illicit medications?
Any reset? No, doctor.
Okay. Do you have any family history of similar condition?
No, doctor.
Any family history of not?
No, doctor.
Mm-hmm. Okay, so I'm sorry for asking this question. Any ear piercing,
No, doctor.
tattooing,
No,
sharing needles,
never, doctor.
any casual relationship?
No, doctor.
What you are doing for living?
Yes, I am a teacher.
Okay, where is the picture? How
Teacher,
much
teacher. Yes.
the picture of the patient? How much your condition impact your job and usual daily activity?
Yes, doctor, it impact me a lot. I can't go to the work at the morning. I go always late to my work, so it impact me a lot. So you know, yes, you know the picture of the patient. So
I didn't see it.
sorry.
The picture of the patient
Yes,
you
the
have?
patient. No, 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 doctor, sorry.
Okay, no problem. Okay, so I'm sorry for that. I'm trying to help you regarding this, and also we can provide you sick leave and reporting letter for your job. Is
Thank
that
you,
okay?
doctor. Thank you, doctor, very much.
Uh,
Thank you.
yeah. Do you drive?
Yes, doctor.
Yeah, so I advise you to stop driving until further assessment. Is that okay?
Thank you, doctor.
Okay, so do you smoke?
Yes, doctor.
How many cigarettes? At least how long?
Yes, I smoke 20 cigarettes yes, per 10 years. 20 cigarettes per day for 10 years.
Okay, so I advise you to stop smoking. The smoking is hard for your health. Is that okay with you?
Thank you, doctor.
Do you drink much alcohol?
Yes, doctor.
How many units per week
Yes,
you are drinking?
on vacation only, doctor. 1 or 2 units
Oh,
per week.
okay. So may I examine you now?
Sure.
Okay. Yeah, I need the vital chart of the patients, full observations,
Yes, blood pressure.
including the.
Yes, blood pressure 120/70, pulse 70, temperature normal, blood sugar normal. Yes.
Okay. Okay. So I need also to over urine deep stick for this patient for proteinuria.
Okay, doctor. Thank you.
Okay. So I'm going to start examination by examining the back of the patients. Could you please expose your back for me?
Yes, doctor. Now exposed.
Okay. Do you have any pain in your back now?
No, doctor.
I'm going to look if there's any deformity, any tenderness.
Yes, doctor. This kyphosis and the loss of lumbar lordosis.
Okay. So
Okay.
I'm going to check the movement of the back, forwards and backwards, and right and to the left.
Okay, doctor. I think there is limitation. Yes.
Okay.
Mm-hmm.
So yeah, I'm going to examine the yes. I'm going to examine the leg for the back of the leg. Yeah, if there's any pain
In the
or
back of my
swelling.
in the leg.
Yes, actually, yeah.
In the leg, normal, doctor.
No pain. Okay.
No pain.
So
Yes.
I'm going to examine the neck. If there is any restriction of the movement, also forward, backward.
Some restriction, yes, doctor.
Okay. So yeah, I would like to check to do a occipital test and
Oh,
modified sugar test for this patient.
okay, doctor. No need.
Okay. So
No
I'm
need.
going to start examination by examining the hand if there's any clubbing.
No.
Okay. So I'm going to check the pulse if there's any yeah, large volume pulse. The rate,
Normal. Large volume
collapse.
pulse. Okay, no.
Okay, so I'm going to check the skin behind the ear if there's any skin rash.
Yes, no.
Okay, so I'm going to check the eye if there's any redness, the visual acuity, the bell.
Yes,
Below.
visual acuity. It is normal. There is red color in the patient. Okay. What do you need also?
Okay, so I'm going to auscultate the chest. Yeah, from the up if there's any crepitations, and also auscultate for the aortic rigor.
Okay, in the apical there is no crepitation. Okay, and what need also? Sorry, doctor. What need?
By basic crepitation.
No.
Fine, but
2 minutes
No.
okay,
left.
JVB.
GBB normal. No.
Okay, the abdomen if there's any mass or organomegaly.
No, no, doctor.
Okay, so may I know what is your concern?
Yes, doctor, what I have? Why I am struggling with walking during walking?
Okay, so I'm sorry for that. Actually, after I'm talking to you and after examining you, most likely you have a condition which is called ankylosing spondylitis, in which there is a disturbance in defense system. Instead of attack the bug in your body, it attack your joint and also sometimes attack different parts in your or in the body. So a result from similar manifestations that you are having. So what we are going to do now, we are going to provide you some painkiller as soon as possible, and we are going to run for you some blood tests and some scanning to confirm our diagnosis, and we need to involve a group of specialists in which includes the joint doctor, okay, and yeah, and the eye doctor and other specialties according to your needs, okay.
Okay.
So also we need to be evaluated if you are need to be admitted or not. Do you have another concern?
Do you will admit me, doctor, in the hospital?
No, just we need to be evaluated.
Okay, doctor. So why my leg has pain, doctor? Sorry.
Yes, because Yes, you have been suffer from one of the association of this condition, which you call the Achilles tendonitis, in which there is the soreness affect the back of your foot, yeah, and swelling result from this.
Okay, doctor. Thank you, doctor.
Unable to walk, yeah.
Okay, time is
So we
time is up.
advise you to stop driving and stop smoking. Okay.
Okay, doctor.
Okay, examiner question, Dr. Mahmoud.
Okay, please tell me your differential diagnosis. Sorry,
Yes.
present to me your case and tell me the differential diagnosis.
Okay, Mr. Sami, I think 35 years old, presented with inability to walk since long before 2 days, and he has recurrent attack of this before 1 year ago. Apart from that, he has yes back pain in the lower of his back. Okay, and he's also on examination of this patient, he has also features or manifestation going with ankylosing spondylitis in the form of there is a tenderness in the lower back, and also there is kyphosis and sclerosis and loss of lumbar lordosis. There is a restriction of the movement in the back and the neck also, and he has some vision problem and redness in his eyes. Yes. Apart from that, I could not appreciate any finding. The oxybate wall test and the sugar modified sugar test you mentioned for me, no need. Just
Okay,
yeah.
doctor.
If
Okay,
it's
so
positive.
so yes, so the patient complain of difficulty of walking. What is the gait of the patient?
What?
What is the gait? Patient,
Yeah. Okay.
yes, patient has
The,
difficulty of walking. Did you try to
uh,
walk him?
yeah. No. No. Actually, no. I
Okay,
didn't ask the patient to walk.
okay, doctor. Okay, so what is your positive signs in this patient?
What is the what?
Positive signs, positive finding.
Positive.
Yes, positive
Okay.
finding.
In our examination.
Yes.
Okay. When I examine the back, he has the tenderness in the lower back, and also he has some deformity, like
Yes.
scoliosis, kyphosis, and loss of lumbar lordosis, and also he has
Yes.
restriction of the movement in his back and his neck also. Okay, and he has redness, vision problem in his.
Okay. What is the
And
what is the
also,
cause?
yeah, regarding the back of the leg, yeah,
Yes. Okay.
he has actually tendonitis now, yeah.
Okay. What is the cause of red eye in this patient?
Yeah, it could be anterior uveitis associated with this condition.
Okay.
Yeah,
Okay. What any other causes?
like conjunctivitis also.
Yes. Okay. Okay, doctor. What is your what is your investigation?
Okay, regarding the investigations, I will do a basic investigation, yeah, in the form of full blood count and inflammatory markers, ESR and CRP, and also renal function test with electrolytes in this patient. And also I will do liver function test, and I will do the urine analysis for proteinuria. Okay,
Yes.
specific investigations, I will do yeah, sacroiliac X-ray. Okay, and I will do HLA B27.
Yes.
Okay, and I will do yeah, okay. I will do investigations to search for complication, associated complication,
Like
like
what?
the chest, yeah, the chest X-ray and the high resolution CT and pulmonary function test. And for the heart, I will do ECG and echo. Okay, and also one of the complication like amyloidosis. Also, yeah, we can do renal biopsy or snip from the subcutaneous fat.
Okay, doctor. And about his eye?
Yes, about his eye, yeah, visual Yeah, we can take a swab. Just.
No sweat. Okay. Still sample examination. Okay. Okay, doctor, what is the treatment of this patient?
Yes, non-pharmacological education and counseling about his condition, MDT group, okay, and other pharmacological like non-steroidal anti-inflammatory drugs. If no improvement, yeah, anti-modified rheumatoid, anti-rheumatoid drugs also. And if no improvement, we can add biological treatment.
So in this patient, what is the treatment?
Yeah, in this patient.
Yes, in this patient.
Yeah, I will provide him with the painkiller, like non-steroidal, as soon as possible.
Yes, doctor.
And I will start, DMARD also.
DMARD in this patient? Okay, doctor.
Okay, DMARD axial. No, most likely biological first.
Yes, Dr. Sar. Okay, what else? What else apart from non-steroidal and biological?
Yes. Anti.
No, apart from medication, this patient, any advice for him?
Yes. Apart from there is advice like regular exercise and morning also like swimming. Okay,
Yes, doctor.
can help him.
Hydrotherapy. Okay, Dr. Sarah, thank you very much.
Yeah.
Thank you.
Thank you.
Okay, Dr. Sarah, start, Dr. Bassem?
Yeah. Your comment. Well done.
Okay.
Thank you.
Okay, you did well, very well, Dr. Sarah, really. But the only point is that you start examination too late. Too late. This patient, anyone can know the patient ankylosing spondylitis, but the problem in examination. Examination will take more time. So I think to start examination too early, you start examination at 9 minutes. That is the first. Number two, it is a common mistake in the exam. You didn't examine the complaint, the patient inability to walk. So first of all, let the patient. Okay. So
sorry, continue. Yes.
Okay, Dr. Bassem. So first, let the patient walk to see the gait of the patient because it is the complaint of the patient. And also in the examination, you miss many points like chest expansion. I tell you that Schubert test and Oxford test no need to see the examinations, other examination. So chest expansion didn't examine. The back you examined it well, chest not examined, and the heart. I think you didn't examine the heart. Okay, that is the second.
I'm auscultate for the aortic regurgitation in the heart.
Okay, doctor. Okay, and yes, and you didn't examine the back of the heel. Achilles tendonitis. You didn't examine the Achilles tendonitis of the patient. But the only mistake that you start examination very late. At the first, the patient come with you with inability to walk. So the first analysis, what do you mean about difficult of walking? I will say to you, yes, doctor, I can't walk. Okay, tell me, it is due to weakness or there is pain? I will tell you, yes, doctor, there is pain. Any pain in the leg? Okay, any other pain in your body? I will tell you where, doctor. You tell me in the back. Yes, I tell you in the back. There is pain. Okay, there is pain where in the back. This pain there is any stiffness? Yes, doctor, there is stiffness. It is increased with rest and decreased by movement. Yes, doctor. And I think I listen to many people that it is you should tell the patient, is this pain awake you from sleep? I will tell you, yes, doctor, I wake up from sleep due to this pain because ankylosing spondylitis awake the patient from sleep at night, and then walk, and then return to sleep again. Yes, that is the analysis. And then you should analyze the whole body from up to down about the vision in the neuro, and also there is any weakness, and then the cardio, any difficult to breathe, any shortness of breath, any missing heart, and the chest, any chest pain, and in the muscle, any Achilles tendonitis. And then start examination early, because this patient need at least 7 minute examination. You will start with examination of let the patient walk, and then this patient go to the wall first, and check the occiput test, and then we will see the loss of lumbar lordosis and kyphosis, and then check the Schubert test, and then check the limitation in the axial, and in the sacral, and in the thoracic. But yes, but very fast. And then let the patient to the bed, and start examination from the hand to the chest and the cardio, and at last the Achilles tendonitis. But you did it very well. But advice from me, Dr. Sarah, start examination in this patient very early. Thank you, Dr.
Yes,
Sarah.
yes, you are right. Thank you.
You start examination at 9 minutes.
Yes.
Yes, and there is also a mistake. You didn't tell me the red flag of back pain. Any numbness. You tell me weakness and numbness, but you didn't tell me uncontrolled water work or the bowel. Yes, the compression science. Thank you, Dr.
Yes, just yes, thank you. I'm asking this when analysis for inability to walk. I'm asking
Yes,
regarding sensation and weakness.
I think if the patient towards you, it will be good to هيبقى كويس يعني لو انت شفتيه بدري فعلا. Thank you, Dr. Sarah.
Okay. Thank you,
Yeah.
thank you.
Thank you, Dr. Mahmoud. Very nice case and presentation. First time to see ankylosing with Achilles tendonitis as a presentation. Not
Yes,
only,
yes, actually.
yeah, not only as a pain, even inability to walk. But Dr. Sarah get the case. She catch the diagnosis, and she also tried to rule out the other reactive arthritis, the inflammatory causes. However, the examination was missing some parts, which is very vital. In this condition, you should examine the complaint itself, the walking, as Dr. Mahmoud said, the walking, or why he's unable to walk, and how is the step, how is his gait. I think this patient gait will be like maybe Dr. Mahmoud, you can correct
Yes,
me.
this patient will if he the gait will be
Limited.
will be limited, and يعني catch his hand in his leg. He will catch his hand in
Okay,
his leg,
because of
and
the pain. Yes.
because of the pain. Yes, that is the gait.
Okay. But we didn't ask Dr. Sarah about the differential. What do you think the cause or the inability to walk differential in this scenario? Dr. Sarah.
Yes, I didn't ask.
Regarding the differential as general or just inability to walk?
Okay, I forget initially to ask candidate the differential of the case from the start, I mean outside, and after they catch the case. Let's do both of them. Inability to walk in young patient, 35 years, male. What you can say, what you wrote in your paper. And after that, we'll do differential for the case itself as ankylosing tendon,
Yeah.
tendon, Achilles
No,
tendonitis.
no one will write
Yes.
ankylosing spondylitis. No one, Dr. Bassel.
Arthritis.
Yes,
Yeah.
I know. It's difficult to be
Difficult.
thinking about. Yeah.
To
Okay,
be
so
predictive, yeah.
yeah, what is the differential of inability to walk in young patient, Dr. Sarah?
Yeah, it might be weakness and also like any
Okay,
pain
weakness.
or
No, no.
trauma,
G-
arthritis.
No, give me differential as disease or conditions.
Okay, disease or condition. Okay. So ankylosing it is. Um,
By the way, ankylosing itself will not cause it. Apart from the Achilles tendonitis.
Any treatment can cause weakness, yeah, or any arthritis,
Okay, let's focus on this
like
part, the
gouty
motor.
arthritis, or
Okay, no, don't think about the joint. The inability to
mhm,
walk means weakness. In young patient, what do you think the weakness in young
like
patient?
hypokalemic periodic
Okay,
paralysis,
yes, this is the
hypoxic
one I
periodic
need.
paralysis, yes,
Okay, this is regarding the weakness. What else?
yes, conversion or functional disorder,
Okay,
um, yeah, hemiplegic migraine, other causes TIA, stroke,
a stroke in young patient,
yes,
35 years. Is it wise to put stroke here? I don't think. Unless he is having diabetes for long term. What other disease can
or
affect the motor, the power?
motor neuron disease. I didn't think
Young
in this.
patients, again, young
Multiple
patients.
sclerosis, multiple sclerosis.
Okay, yes, this is one of them. What else? Myasthenia,
Mm.
Guillain-Barré,
Yes,
right?
Guillain-Barré, yes, yes.
So any motor or muscle power weakness or affection, you can put this
Mm-hmm.
as a motor part. Okay, what
Mm-hmm.
about the vascular part?
Vasculitis, that's simple.
Okay, vasculitis.
Post intermittent claudication.
Yes, you ask this question.
Mm.
The claudication of vasculopathy or complication of diabetes, right?
Yes,
Particularly type 1 or uncontrolled type 1 diabetes. This is another differential. So vascular part and motor or neuro part. And the third will be sensation or sensory part. You mentioned already
peripheral
periodic.
neuropathy, yeah. Mm.
Peripheral neuropathy, exactly. Or Charcot-Marie-Tooth, right? With cavus and all this will be associated. So you have to put good differential initially away from the case. Now the diagnosis, ankylosing or
For
Achilles
inability to walk,
tendonitis.
actually, is several, yeah,
Sorry.
different. Like
Yeah.
many differential for
Yes, you
inability
have a
to
lot of
why
them.
is
And by
difficult.
by the way, don't give the less common. You have to mention the common, particularly related to the age group. In young patient, you have to put wise differential for this young patient. Okay.
Okay.
Let's go now to the case itself. Achilles tendonitis as a differential. What do you think the differential will be wise here? Give me differential makes sense related to the inability to walk
Mm.
and because of Achilles tendonitis.
Okay, ankylosing
Okay.
and psoriatic arthritis also.
Yeah, so you can say reactive arthritis cause. Yes, exactly.
Reactive also, yeah.
Yeah. And what else? Reactive ankylosing. Sorry, reactive as ankylosing and
Mm. Neuropathic.
enteropathy. Exactly. And Behcet.
Ah, yes.
And we mentioned the reactive one. So all inflammatory causes or seronegative arthritis. Reactive, particularly reactive. You had to put reactive in such age, sexually active, and he had
Mm.
recently or unprotected sex, for example. He had discharge, but you will say against that one, two, three. But still, the reactive arthritis in such group will be a wise differential. So reactive arthritis and ankylosing our case, and you can see enteropathic arthritis, psoriatic arthritis as well. So seronegative arthritis will be, or inflammatory arthritis will be a good differential in the all as all differential. Okay. Apart from that, as a comment, yeah, the examination was late, although the case was expected to be ankylosing. Since he said I am moving, the pain is improving after I move after early morning. So it's equal to in brackets ankylosing, or let's say zero negative or inflammatory cause related to the back pain, which is good. You picked up early the back pain. The patient is having back pain. But don't forget, as Dr. Mahmoud said, don't forget to roll out the alarming signs of back pain, the compression, I mean. However, it's not common. Inflammatory means no mechanical, so it will not be associated with compression or fracture or whatever. It's just inflammation. Regarding the concern and the explanation of the disease, always, Dr. Sarah, you are explaining and giving the plan of management. And usually I'm saying answer the concern shortly according to the concern. Don't be volunteer to tell because you might have another concern which is, for example, doesn't make sense or makes sense for the patient, but doesn't make sense. You tell him the investigation, what I should do for you. No, he should know about what he need to know. Okay. In this condition, for example, will I walk again? Is it curable? So in order to shorten your time to explain the other things, you have to answer shortly according to the concern. Okay, don't be volunteer to explain more. Clear?
Okay.
Driving. Yeah, some doctors wrote about driving. Why I should ask this patient to stop driving. So for two reasons, we can ask this patient to stop driving. One of them,
The
which is
vision,
vision, exactly. He has it now,
restricted
already.
movement, yes.
Exactly. Anterior uveitis, one of the causes. He cannot see well. And the other thing, limited neck movement. He cannot move full lateral movement of the both necks, both side of the neck. The examination steps, I think Dr. Mahmoud mentioned from A to Z. Don't forget the 6 A's or 7 A's association with ankylosing, started from anterior uveitis, AV block, aortic regurg, amyloidosis, and Achilles tendonitis, and apical fibrosis. This is the sixth. And one more missing, I think axial spondylitis. Okay, the image and the investigation, everything mentioned well. As knowledge-wise, you are doing well, but as examination, you have to have good time and utilize your time for the examination. You have a lot to examine in the enclosing.
Yes.
Okay. Okay. Dr. Mahmoud, you want to add any comments? Anyone want to add comment? You have any question, Dr. Sarah?
No, thank you.
Okay. Your case, Dr. Mahmoud, I will give you 2 minutes to prepare yourself. Mr. Ali, presenting with
Sir,
constipation. Yes. Yes,
it
Dr.
is
Khalid.
better to explain ankylosing spondylitis as autoimmune disease or as
Yeah, I am against this also. It's not autoimmune. It's soreness in your soreness in your joint, and it might affect other parts in your body. Okay. Yes, you might say it's defense system attacking other parts, but it's in the mainly it's inflammatory. So it's soreness. Okay, Dr. Sarah, but you cannot put it under the term of autoimmune disease. Clear? I agree with Dr. Khalid. Thank you, Dr. Khalid, for this. You remind me. Actually, I was about to mention, but you remind me. So it's important to explain well. If you will not explain and he didn't ask you, don't explain. What I have, you have a condition which is having soreness in your joint, in your tendon, or in your muscle, and you can say it's unknown mechanism. Some theories saying it's running in family. Right? That's why we are doing HLA B27, right? It might be positive in some conditions, but mainly it's soreness, not as autoimmune disease. Okay, back to the comment, Dr. Mahmoud, your case, Miss, I told you, right? Mr.
Yes,
Ali.
doctor.
Okay,
Yes,
just be ready. I will read the comments quickly. And
I'm
as
ready.
usual, with every long clinical consultation case, please, the candidate can write the differential initially and later on, just to improve the skill of a differential. Some doctors, they are failing in the differential, by the way. That's why we want to focus on it. I will read the comment quickly. Episcleritis. Episcleritis is very common with rheumatoid. Need to stop driving. I explained already. Yes, Achilles tendonitis, not as an Achilles tendonitis. Again, it was for the neck, limited movement, and for the anterior guides. How to examine Achilles tendonitis? Any part in the body you want to examine as a musculoskeletal, look, feel, move. Any organ or part in the body with organs inside, you will do inspection, palpation, percussion, auscultation. Easy, take it easy. Don't make the thing complicated. How to examine the Achilles? I will look at it. There is tenderness. Sorry, there is redness. There is a swelling. This is by inspection. I mean, look. The feel. I will feel over it. You have any different sensation? No, doctor. Okay, is it warm? I will compare both sides and up and down above the tendon itself. And the last thing is the movement. Move it by yourself. He can move or no, and I will move it by myself. So the passive and active. I will try to move the joint up and down, right and left, eversion, inversion. I will see if there is any limitation or no. Always do in comparison. So the right to the left. Compare both together. That's it. This is fair enough. If there is infection, you can offer lymph node related to this part. But it's not common as a tendon examination. Okay. Apart from that, you have to examine the back after exposure, of course. If there is sucks in over the leg or over the feet, please offer remover of these clothes. Don't examine over any clothes, any part in the body. By the way, since he's having difficulty or inability to walk here, you can offer the sensation. However, it will be spared. Nothing here will be affected in the sensation. Okay. Back to the comment. Except before starting infliximab, need to screen for TB and hepatitis. Yes, this is a complementary comment. Thank you, Dr. Tani. But it's the option after two non-steroidal anti-inflammatory. Don't say DMARDs. Okay. So they might start the biological therapy immediately after failure of two DMARDs, either etanercept or adalimumab or infliximab, even the rituximab as well. Trauma as a differential, okay, you can put it. That's why it's important to rule it out in the complaint analysis. Thank you, Dr. Nahla. Peripheral neuropathy, yes, I agree to put differential diagnosis of peripheral neuropathy for difficulty to walk. Multiple sclerosis, definitely you have to say the multiple sclerosis, myasthenia gravis, Guillain-Barré, or the neurological disease, you have to put it once you have inability to walk. You expect the motor part, not the inflammation part or the mechanical part. What's disease? Cord compression metastasis if you have mechanical cause. You can say this, Dr. Nahl. Okay, before, yes, I agree with this differential. Guillain-Barré syndrome, transverse myelitis, trauma, disc prolapse, definitely right. Infection, transverse myelitis, HIV, okay. Dr. Ala put another big term of differential under umbrella of upper motor neuron or lower motor neuron, which is very good comment. Lower motor paroxysmal myopathy, so the nerve, the muscle, the the muscle and nerve, and peripherally, paroxysmal myopathy, or the junction between the nerve and muscle. Guillain-Barré anterior, or sorry, acute intermittent porphyria, lead poisoning, hypokalemic periodic paralysis. This is for lower motor, upper motor, multiple sclerosis, transverse myelitis, spinal cord injury, trauma, tumor, disc, anterior cone syndrome, and you can add also spastic paraparesis. You can add Charcot-Marie-Tooth. Okay, this also can lead to neurological weakness. Tendon, hot, redness, exactly, Dr. Thar. Is there any need for neurological examination for lower limb? Dr. Salma, you can offer it. You will never have time to do all these things. Now you are focusing on the diagnosis of ankylosing. So you will do the examination of ankylosing. Started from the head, occiput wall test, the limitation of movement, modified Schober test, the kyphosis, loss of lordosis, and modified Chopard, as I mentioned, ankylosing, the apical fibrosis, examination by the chest, expansion of the lung, the heart for aortic regurg, the pulse for AV block, the kidney for ballotment, and you can also add dipstick, urine dipstick for amyloidosis, and the back itself, and if there is or sacroiliitis, the area of sacroiliac joint, and the gait, of course, you will start with the gait and the tendon itself. This is the main complaint. So you have to start with this, then you can go to the upper part of the body to find out the other manifestation. Okay. Thank you, Dr. Sarah and Dr. Mahmoud. Let's start the second case. And again, everyone write his differential constipation for young patients.
This old patient or young patient?
How old is he? I
الناس اللي
forget.
قاعدين في UK ولا
65, I think. Yes.
Okay, so you're
زمان
old.
مختلف.
Constipation in old patient. I need wise differential from everyone. Okay, 65. Yes, let's start. Here you go, Dr.
Okay.
Mahmoud.
Okay, good evening. I am Dr. Musa, doctor in the clinic today. Let me confirm you. You are Mr. Ahmed, 65 years old.
Yes, doctor.
Okay, Mr. Ahmed, we are ready to discuss about your company and also to examine you. Is it okay with you?
Okay, doctor.
Okay, brought to my knowledge that you have hard motion. So please, could you tell me more about that, please?
Yes, doctor, I'm troubled from this hard motion since 6 months back, doctor.
Sorry about that, Mr. Ahmed. Mr. Ahmed, can I know before 6 months it wasn't no hard motion, yes, or
Yes,
no, or any previous
doctor.
attack? Can I ask you how many times you go to the bathroom to evacuate your bowel? How many
Yes.
times per day or per month?
Yeah, actually, doctor, yeah, every weeks I'm bathing every 3 to 5 days, yeah. And sometimes now it works for me more than 5 days, even.
Okay, it is alternated with loose motion or only hard motion?
No, doctor, just hard motion.
Just hard motion. Okay. What about your diet, Mr. Ahmed? It is balanced diet? Any change in your
Yes,
diet?
doctor, I'm trying always to eat balanced diet.
You eat fibers and take sufficient water, fluid, sorry.
Yes, doctor, yes.
Okay, what about your physical activity? You move and doing daily activity normal?
Yes, doctor, as usual.
Do you have any mouth sores, Mr. Mouth sores?
What?
Any mouth sores?
No, doctor.
Any difficulty swallowing?
No,
Do you have any tummy pain or tummy swelling?
no,
Any tummy distension?
no. Sometimes this hard motion, yeah.
Tummy distension?
Yes, sometimes.
Okay. There's any heartburn? You feel heartburn or any acid brush?
No.
Okay.
Yes, doctor, regarding the heart pain, yes. Yes, I have heart pain also.
Is heartburn? When it started
Yes.
exactly? When it started
At the
exactly?
same time, doctor, yeah.
Okay. Mr. Ahmed, do you notice any bleeding from back passage?
No, doctor.
Any pain while you passing stool?
No, doctor.
Okay. Do you feel any? Do you have any rise blood temperature?
No.
Do you feel tired?
Yes, doctor, actually I have tired, yeah.
When it started exactly? This tiredness?
Yes, at the same period, doctor.
How many meters you can walk until sorry, in specific time you have this tiredness, more in the morning or throughout the day?
No, doctor, I think it is not related.
Anyone notice that you are paid than before?
Yes, doctor, yeah. My wife, she comment regarding this.
Any weight changes recently? You lose weight?
Yes. Yes, doctor.
What about your appetite?
Yeah, doctor, I think my appetite is affected. It become poor during this time.
Sorry about that, Mr. Ahmed. Mr. Ahmed, do you have any weather preference? You prefer hot weather or cold weather?
No,
Do you feel any dizziness, any spells?
no,
Do you have any joint pain?
no.
Any back pain?
Yes, doctor, I have back pain.
When it started exactly?
Yeah, it started for me, doctor, yes, before 2 months ago.
What is the nature of this pain?
Okay,
dull aching?
dull aching. Yes, dull
Dull
aching,
aching.
doctor.
Dull aching. Where does that exactly? In the upper or lower back?
In the middle of my back, doctor.
Does it move to any side, like to your flank or any place?
No,
Can you how much you rate this pain? 1 is minimum and 10 is maximum. So how much you give this pain?
yeah, doctor, sometimes 4 to 5 and sometimes even 6.
Any morning stiffness?
No, doctor.
Any trauma recently?
No,
Do you have any weakness in your body, especially
no,
your leg? Do you have any?
no, doctor.
Do you feel any numbness in your leg?
No.
Okay. Any change in water work, like increase in frequency or increase in the amount?
Yes, doctor. Actually, I think the amount of my water work it become more.
Okay. Any fluency in your in your water work?
What?
Any fluency urine? Do you see any fluency urine?
No, doctor.
Sorry about that, Mr. Ahmed. Do you lose control of your water work?
No, doctor.
Okay. Any vision problem, Mr. Ahmed? You have any vision
No,
problem? Do you have any headache?
no,
Any racing heart?
no,
Do you have any chest pain?
no,
Any difficulty swallowing?
no,
Okay. Do you have any cough?
no,
Okay. Do you have any long-standing disease should be aware, like increased blood pressure or increased blood sugar?
never, doctor.
Any previous admission in the hospital?
No,
Any previous infection?
no.
Okay. Can I know what's your medication list?
Just took some painkiller, doctor. Sometimes.
For your back pain?
Yes.
How
And
frequent?
also,
Yes. Okay.
yes, just yeah,
How frequent?
2 to 3 times sometimes per day.
Does it help your back pain?
There is little improvement, doctor, but
So,
regain back for me. Yeah.
do you take any mood, any drug for mood, any medication for mood?
No, no, doctor. Just took some vitamin supplement. Took
Okay.
it, yeah, because of this back pain.
Okay. Do you have any family history of cancer?
No.
Okay. Can I know what you do for living?
Yes, doctor. I'm teacher,
How much
but
the
now
symptoms?
I'm retired.
How much the symptoms impact in your daily activity?
Yes, doctor. It impacting me more.
I'm sorry for that, Mr. Ahmed. I hope to diagnose you and give you suitable treatment. Do you smoke?
Yes, doctor.
How many cigarettes and for how long?
Yeah, I smoke like 15 cigarettes. Sometime 20 cigarettes per day. Since long time, doctor. I didn't remember it.
I advise you, Mr. Ahmed, to stop smoking. If you want, I can refer you to smoke cessation clinic if you want. Do you drink alcohol?
No.
Okay. Can I examine you?
Yes, you can.
Okay. First, I want to go to the back. I want to see the back of the patient.
Okay.
Okay. I want to see if there is any tenderness, Mr. Ahmed.
Yes, now there is tenderness, doctor.
Okay. I want to see if there is any swelling, any hotness at the lower back.
No.
Okay. Any deformity in his back?
No.
Okay. Okay. I see the back now. Now the patient is sitting in the bed. I want to see the hand to see if there is any leukonychia or chylonychia. Also, I want to see the pulse and the blood pressure sitting and standing. And I also
No, yeah, just
okay.
wait, doctor. Yeah.
Okay,
In
I
the
will.
hand, no leukonychia, no, yeah, but there is clubbing, doctor, when you are going to see the hand of the patient.
There is scrubbing.
Yes.
Okay. Then I will to see if there is any proximal myopathy.
What?
Proximal myopathy.
No, negative.
Okay, then I want to the eye for any jaundice or pallor.
The patient's he's pale, not
Pale, okay.
jaundice.
Okay. Okay. Mr. Ahmed, do you have any cough?
No, doctor.
Any cough of blood?
Yes, doctor, yeah.
When it start exactly?
Yeah, I started, doctor, since this period, doctor.
So, how many times you can you give me the amount? It is large amount.
Yeah, I started for me like gradually small in amount, but it seems now it become more, doctor.
It is pure blood, Mr. Ahmed, or with film streaks with film?
Yeah, sometimes pure blood and sometimes with flame.
Okay. Do you have any nasal, any bleeding from other orifice, like your nose?
No,
Any deformity in your nose?
no,
Any nasal crusting or stagnation or stiffness?
no, doctor.
Okay. Okay. Any history of travel recently, Mr. Ahmed?
No,
Can I ask you private question? Do you have any history of sharing a needle, tattoo, piercing,
no,
any casual unrelated relationship? Sorry, casual
no,
unprotected relationship. Okay.
no,
Do you have
doctor.
any history of blood transfusion?
No.
Okay. Then I want to listen to the chest. If there is any crepitation.
No crepitation.
No crepitation. Okay. Then I will to the heart to see the apex if it is displaced, and also to listen if there is any P2 pulmonary, if there is any cerebral.
No, negative.
Okay. Okay. Then I will go to the abdomen to see first palpation, superficial palpation, if there is any tenderness or any masses.
No, negative.
Okay, then I will do deep palpation to the spleen and also to the liver. Okay.
No,
And,
negative.
okay, I want to do a digital rectal examination to the patient.
Okay. No need, doctor.
Okay, then I will go to, I want to do lymph node. It's axial and all, it's axillary and also submandibular and
Okay.
subcervical. And also I want to do inguinal lymph node if there is inguinal lymph node enlargement.
Okay.
Okay, then I
No
will.
lymph node.
Okay, then I will. I want to finish my examination to see the skin turgor if it is dehydrated or not. Okay,
Okay.
is dehydration?
No, not dehydrated.
No dehydration. Okay. Then I will see if there is any lower limb edema or any rash.
No.
Okay. Okay, Mr. Ahmed, can I know what's your concern?
Yes, doctor. What I have, doctor? Just I have a cancer, doctor. Please tell me.
I really appreciate and to understand your words, Mr. Ahmed. Cancer is one of the possibility of your case. It is a type of cancer called multiple myeloma. This is a cancer of in the bone, and also cancer type of cancer which arises from the blood. And I am sorry to you that it is a serious disease. So we have to do some blood tests and also some scanning to your back. And
2 minutes left.
yes, and do some blood scan to your your chest. And we will update you about the result. Do you have any other concern, Mr. Ahmed?
Okay. So, doctor, is it curable?
I am sorry to tell you that Mr. Ahmed, I will refer you to cancer doctor. If it is approved, it is a cancer, but I think the treatment option is limited in this type of cancer. There is a treatment which is bone transplant, but it will take time.
Okay.
What we need to do now, Mr. Ahmed, because this hard motion and also increase your water work, so we have to measure some salts in your blood. It's called the calcium. If it is increased, we have to admit you in the hospital to give you some fluid, and also help you about your hard motion.
Okay.
Any other concern, Mr. Ahmed?
No, thank you.
I am sorry, Mr. Ahmed, for this bad news. At the time being, I will do some blood test and also some scan to your back, and also we need the scan to your skull bone, and also to your chest. And I will update you about the result.
Okay.
Okay.
Could you please present your case for me?
Yes.
Okay, Mr. Ahmed, 65 years old, presented to me with constipation associated with polyuria, and also there is back pain. It is a mechanical back pain, decreased water work, and also he had heartburn. It is associated with hypercalcemia. Mr. Ahmed, during examination, there is a clubbing. And also there is clubbing in his hand, and also there is pallor. There is pallor, and also there is crepitation in his lung.
No crepitation.
No crepitation. Okay, he is coughing of
Yeah.
blood. Yes, I don't know why really, but he is coughing of blood. So my first special diagnosis, I think Mr. Ahmed has multiple myeloma. It is confirmed by there is pallor, which is anemia, and also back pain, and also there is hypercalcemic symptoms in the form of heartburn, and also polyuria and constipation. Okay, and I think
Any other differential, doctor?
yes, maybe hyperparathyroidism. Hyperparathyroidism, my second special diagnosis, and also maybe sarcoidosis, and also maybe Mr. Ahmed was a smoker, so maybe small cell lung carcinoma.
Small or another non-small?
I think small.
Okay.
Smoker. I know.
So what is your workup?
Yes,
regarding this?
yes. According to Mr. Ahmed has hypercalcemia, so I have to measure the calcium. If the calcium increased, I will admit Mr. Ahmed to give him some fluid. And apart from that, I will do CBC, looking for any anemia or any lymphocytosis or leukocytosis, looking for any infection, and also inflammatory marker, ASR, CRP, and also electrolyte, calcium, potassium, magnesium, and phosphorus also. And I will do alkaline phosphatase, and do also parathyroid hormone. And to confirm my diagnosis, I will do X-ray. Yes, X-ray to the back, and also we need stool culture according to his complaint is constipation. If I need to do colonoscope or stool culture or stool analysis, and also I want to do urine culture, and according to confirm my diagnosis, it will be by multiple myeloma. I think hemoglobin electrophoresis or protein electrophoresis, and IgG measure. It will be increased in IgM, and the Bence-Jones protein in the urine, and also we need the skull X-ray.
Okay. So, okay. Regarding the treatment for this patient,
Yes, treatment, I will admit Mr. Ahmed for fear of hypercalcemia and the risk of cardiovascular complication. So I will admit Mr. Ahmed and give him some fluid, IV fluid, also IV fluid, yes. And the treatment will be by IV fluid and some laxative. And also I will make a multidisciplinary team of cancer doctor, sorry, blood doctor, yes, blood doctor, and also gut doctor, and may need gland doctor to give him proper care and planning. If
You are talking to the examiner, by the way.
yes,
yes.
You are saying blood and the gut.
Yes, yes.
yes, gastroenterology.
Yeah.
Yes, gastroenterology, to give him a proper plan and management. If the patient has multiple myeloma, I think it is conservative management, but there is treatment will be bone transplant, bone marrow transplant.
Okay. Okay. So I'm finished.
Thank you, Dr. Sar.
Thank you, doctor.
Still 20 seconds. Dr. Mahmoud,
Okay, Dr. Faisal.
what image you will do here? You mentioned.
Yes, I will do MRI, X-ray, MRI to the spinal cord, and also we need skull X-ray,
Okay, looking for what?
bone. اسمها ايه؟ I forget the name, Dr. Faisal.
Yeah, that's why I ask you.
Oh,
Yes, yes. Regarding the parasite.
no,
Sorry?
the skull bone
Main regarding the.
will be fused, Dr. Basim. Will be
Lytic lesion.
lytic lesion. Yes,
Okay, you mean regarding the lytic region. Okay.
Okay, and you mentioned already the MRI. So if you don't find in the X-ray, you will do MRI.
Yes.
Okay, and I want to add one more question for the tumor markers. You mentioned already the protein electrophoresis and Benz-Jones protein.
Yes,
What?
IgM and
Yeah.
IgG.
Okay. What if you suspect this is a lung mass? What you should do?
Mass in the lung.
Okay. Yeah, you said one of the possibility or differential.
Yes, small cell lung carcinoma.
Okay. And how to do diagnose?
By X-ray and CT and
Okay.
bronchoscope.
Okay. What do you think the lesion will be here? Peripheral or central?
Will be central. لو if small central.
If it's squamous,
Squamous will be peripheral.
still central.
Still central, yes. Adenocarcinoma is the peripheral one.
Yes.
Mm.
All S will be central. Squamous, small or squamous, and the other than S will be peripheral. Even carcinoid is central. Okay. Fair enough for the question. Dr. Sarah will comment, then I will comment.
Yes. Yes, he did well. Apart from few comments in the history, yes, you are analyze the constipations, and you are thinking regarding the hypercalcemia. Just we need from you to ask more regarding the hypercalcemia symptom, like serosity and gravules. Okay.
Yes.
Yeah. And after that, regarding the weight loss, you didn't analyze it. How many kilo and for how long, like this. Okay.
Yes.
Okay. So this in the history. Yes. Okay. Despite you are go back to the chest and to ask regarding the coughing of the blood. Actually, this patient he has squamous cell carcinoma because he's heavy smoker. Just in the chest examination, we need to examine chest, not auscultate just okay. To do chest movement, percussion, focal resonance. Okay.
Yes. Yes.
The patient he has bronchial breathing and and he has just consultation, increase the focal resonance, decrease in movement. Okay, dull impercussions.
Mm. Yes, Dr. Sam.
Okay, this is the most important in the examination of the chest. Apart from that, yes, you examine regarding the lymph node and the back. That is good, and the abdomen. Okay. Regarding also we need to ask regarding the tuberculosis, in contact with ill people having tuberculosis. Also is the most important. Yes, regarding the urinary symptom, also we need to ask regarding the prostatic symptom, because one of the differential might be prostatic cancer metastasis,
So spinal
and
cord.
yes, exactly.
Yes.
The second differential, multiple myeloma, as you mentioned, multiple myeloma, yeah, as the second differential, because elderly patient presented with hypercalcemia and the back pain. Okay, after squamous cell carcinoma, because now your patient also has clubbing and heavy smoker.
Yes.
This regarding the differential diagnosis. You can put squamous cell carcinoma at the top of your differential, multiple myeloma, and meets either from the prostate or other. Okay. Yes. Regarding the investigations, just we need to, yes, you are investigate for multiple myeloma. Also, we need to do MRI spine or scanning of the whole of the body, and also the chest is the most important. Chest X-ray, okay, CT with contrast to look for the cancer, and also bronchoscopy plus biopsy. Okay. Yes, also parathyroid hormone related to diet and serum calcium is most important. Parathyroid hormone itself. Okay. Regarding the management, yes, because this patient now he has hypercalcemia, just it might need to be admitted, rehydration and also fluid. Okay, correction of the calcium. And apart from that, non-pharmacological education and counseling about his conditions and MDT. Okay, so after that, according to treat the cancer itself according to the stage of the cancer, if possible surgery or not, other like chemotherapy. Okay.
Okay, doctor.
Yeah,
Mm.
you did well, Dr.
Very good case, Dr. Sam. Thank you very much. Thank you.
Okay, thank you, Dr. Sarah. Well done, Dr. Mahmoud, as usual. But I have comment on the concern. Again, if he asks you about a concern, don't be volunteer to explain the condition, even though you explain wrong condition, right? You explain
Yes.
about multiple myeloma, which is not the case. So please tell him you might have a cancer, either in your blood or your lung. That's it. Other concern, yes, doctor. Is it curable? You can answer after that, and so on. Okay. And for the multiple myeloma as a cure, there is possibility if they have any possibility to do stem cell transplant, not bone marrow. Okay, stem cell
Yes.
transplant. This is regarding the last part of the concern and the correction of the information. For the performance, you did perfect as analysis of the complaint or the GI as a relevant system, and so on the system review, the alarming signs or the constitution symptoms, which was positive. But again, whenever you have positive complaint or positive finding in the history, ask him, tell me more about it. At least. Okay, so analyze it. Don't skip it. Don't say okay and ask other question. You have weight loss? Yes, I have. Tell me more about it. Or you can specify the question how much over how long. But at least know since when is it related to the condition, to the complaint or not? Or at least he will tell you some of the information. Like I lost Dr. 6 kg. I have been feeling loose or the clothes might be loose now on me or whatever the analysis or the prescription by the patient. Sorry, the description of the patient. But at least ask him, tell me more, or ask him more about it and analyze it. It will give you a clue about the case. Okay. Here in this condition, it's related more to the smoking, which is one of the positive and very dangerous habit. And the case, I think it's more now going to the lung cancer with coughing blood. The pallor related to the hemoptysis, and the lesion in the back may be related as metastasis. Yes, multiple myeloma is still there, but you don't know until you will do the investigation, right? The question for the kidney and genitourinary, you ask about the water work.
Yes. Water work
And
and flossy.
okay, it was positive or polyuria initially. Is it
Yes.
decreased later on?
No,
So
I
it's
don't,
not.
I don't ask.
You didn't ask.
Yeah, I didn't ask. Yes.
Yeah, you have to confirm because the renal failure will come later on. Hypercalcemia initially, and with the time, this patient will have renal failure and the urine will be less. That's why you have to confirm and to conclude the case more with the lung cancer. Okay, what you will explain the hemoptysis related to the multiple myeloma.
Yes.
How you
Yes.
can link,
Lung
right?
cancer. Yes, Dr. Bass.
Yes. Okay. Other than this, I think the differential also was okay. Lung cancer, multiple myeloma, and as Dr. Sarah said, in this age, prostatic cancer with also or bone mets and also lung mets. But still, this patient is cancer patient, whenever or whatever the origin is. Okay. The investigation already mentioned, the clinical judgment was okay, the management plan, multidisciplinary team with the patient, multidisciplinary team equal group of doctor. The doctors or the specialty with the patient, you can mention in non-jargon with the doctor or with the examiner. Please don't tell him gut and blood doctor. Focus to whom you are talking. Okay, you are calling the hematologist, the gastroenterologist, the neurosurgery, or whatever the department. But with the examiner, be careful. You are talking as jargon or medical terms. Okay. Any question, Dr. Mahmoud or Dr. Sarah?
Thanks, Dr. Basim. Thanks, Dr. Sar. Good case, really.
Yes, good case. And I think we covered the topic, all of the questions. I will read the comments quickly. Yes, stem cell, as I wrote, stem cell, not bone marrow. Squamous, I agree, this is squamous cell, Dr. Mahmoud. Is the small cell lung cancer secreting two protein or two hormones, which are small cell lung cancer.
I don't remember, Dr. Basim.
ACTH, always remember the A letter, A. ACTH,
ADH and ADH.
and yes, and the SIADA antidiuretic hormone. So ACTH and ADH, antidiuretic hormone. But small, the squamous cell cancer or carcinoma will secrete
Parathyroid hormone. Parathyroid hormone
related
peptide.
protein, yes, or peptide. So the hyper will be hypercalcemia. Don't forget small cell lung cancer might be associated with Lambert-Eaton syndrome, right? And the small, again, the squamous cell will be hypercalcemia associated as a paraneoplastic. I'm talking about the paraneoplastic part of the gland, of the tumor. Okay, Dr. Gabriel, yes, small cell lung cancer, sorry, squamous cell carcinoma with mets to the bone, parathyroid hormone related peptide, multiple myeloma, cancer prostate with mets to spine. I think this is the most wise answer. Perfect, Dr. Gabriel. Why jaundice? Dr. Sarah asking why jaundice. I think he was pale, not jaundiced. Anyway, if there is jaundice, you can correlate with the liver mets, right? Any patient with mets, he might have liver mets. You can guess it, although it's not common, but you can guess it. So lung cancer with liver mets, or bone meds or whatever. I'm trying to find explanation, but it might be justified by something else. Okay, this is Dr. Jabli. I think he wrote the most correct the differential. Dr. Sarah Bashir, yes, asking to comment after finish, it's better. I intentionally asked doctors to write the differential and to chat in the chat box freely. And I always request from the candidates who are participating not to look at the chat. Why I'm asking that? To make it more interactive and to let the candidate more focusing during the discussion and the conversation. And some of them also can improve the scale of differential diagnosis. Definitely, it will help. Okay. Based on also again that the candidate or the participant will not look at the chat box. I trust them because they are the candidates preparing for exam. So they have to be ready and they should also be answering without looking to the chat box. Lung cancer with binary syndrome, Dr. Dr. Al-Huda, perfect. Dr. Nada, multiple myeloma, squamous cell cancer with bone mets, perfect. She did it also, Dr. Nada. Bowel cancer, Dr. Rivathi, hypothyroidism, hypercalcemia, drug induced. This is as initial differential, it will be perfect. By the way, this is the most wise differential before entering to the case. But it will be changed again whenever you will see the patient cachectic. You have to think about cancer on the top, and you can remove the hypothyroidism because the hypothyroidism patient will be obese or weight gain. But in this scenario, definitely he will be as a cachectic one. Hypothyroidism, Dr. Gabriel, but this is before. Medication, yes, I agreed to mention earlier. Cancer colon, poor diet, hypokalemia, lesions like Fisher. Okay, any differential is accepted to write earlier. And during the discussion with the patient or the surrogate, you can conclude or roll out others according to the positive finding in the history and examination. Hypercalcemia, Dr. Al-Huda, multiple myeloma, sarcoidosis, hyperparathyroidism, paraneoplastic, drugs, colon cancer, adhesions, perfect. Okay, I think all of the medication like opioid, Dr. Sarah. Yes, don't say opioid in the top. Okay, it's not common, by the way. Yes, it could be the case, but it's not common to be as opioid. Unless the patient, for example, is diagnosed as cancer, he's taking a lot of medication, including the opioid, and the opioid will be, of course, as a leading cause of constipation. You can say this is opioid related, but don't say it in the first differential unless you have an evidence in the case or during the discussion. Otherwise, I think before going to the case, the hypothyroidism, hypercalcemia, whatever the cause, you can put, and cancer colon according to the age group. Or drug induced. Some doctors or some patients, they are taking medication or the diet itself, diet habit, which also ruled out by Dr. Mahmoud. Again, back to the drug induced. Yeah, there is some medication can lead to to constipation, but don't specify the opioid itself because not every patient will take opioid. Opioid means there is strong pain or severe, extremely pain, and need strong analgesic, which is the opioid. So it's not commonly to be taken. You can say less water intake, delirium patient or delirious patient, old age, particularly those Parkinson or depressed or stroke patient, hypokalemia, electrolyte disturbance. Okay, but the common is common. Hypothyroidism, all hypercalcemia causes, whatever, from sarcoidosis or parathyroid adenoma or cancer, multiple myeloma with hypercalcemia, I mean, or thiazide, drug-induced hypercalcemia. So you have a lot of hypercalcemia causes. You can put them earlier, but you can roll out some of them according to the case. But hypercalcemia at the top of constipation, yes, it's very common in PACES exam. Okay. Any question or comment? Dr. Mahmoud, Dr. Sarah?
Thank you,
Anyone?
Dr. Bass. Thank you.
Most
Thanks.
welcome. Okay, anyone want to comment? I'm really satisfied with this differential. Who wrote the differential in the chat box? Most of them, they wrote it perfect. And of course, the performance of the candidate today were perfect also, Dr. Sarah and Dr. Mahmoud, as usual. Anyone want to comment before ending the session? Okay, if no more, we can end the session.
Yes,
Thank you.
Yes,
Yeah.
thank
Okay. Okay. Thank you, Dr. Sarah. Okay, see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.